Hello aspirants, welcome you all to Sail to MDS Dental Academy. Hope you all are fine and doing great. So myself Dr. Malay Trivedi, pediatric dentist, assistant professor in College of Dental Sciences. So now aspirant, today we are here with the part 2 of our access cavity preparation. So already in part 1 we have seen about the root canal orifices location, various important laws regarding that, and many clinical and image based questions. So here now we are going to see what are the problems you encounter during your access cavity preparation and how to prevent it. Remember aspirant, this video is beneficial for the Neet MDS student in terms of image based question and clinical scenario, and also for those students who are planning to learn root canal therapy. It may be helpful for them when they encounter such troubleshooting during root canal preparation. So let's start with the video. So the problem number 1, you cannot see pulp chamber in cases like this because of excessive bleeding. So what is the cause of it? So the commonest cause is pulp tissue within the chamber or in the canals. So how will you try to solve the thing? You can enlarge the access by removing the pulp chamber roof without touching the chamber floor. There is an important statement given in the Cohen that never touch the pulp chamber floor unless the floor wall junction is fully seen. You can also place hemostatic agent in the chamber like collagen based materials, gel form, bone wax, cautery or electrosurgery. And you can use a barb brooch to remove the tissue. Now student, very good image based question. So it's a Colacot, it's an absorbable collagen, it's a convenient biocompatible packing material for localized hemostasis. You can also use such a cotton pellets impregnate with a racemic epinephrine, also be used for localized hemostasis. Now problem 2, unable to identify all orifices. Whenever we go for root canal access cavity preparation, it happens usually. What are the causes? The 4 important causes. First is you have not established a complete access. We can see the mouse hole effect. There is a lack of demarcation of a distant floor wall junction. Any presence of restorative materials or calcification. So how could you solve it? Make sure a complete access is performed. You can smoothen the pulp chamber floor to remove calcification and delineate floor wall junction, and go for the use of laws of root canal orifices. Then unable to observe the pulp chamber floor due to inadequate removal of pulp chamber roof, cause improper selection of the initial access penetration point. Inability to see the floor wall junction 360 degrees around. So what are remedy? Return to previous burr, either round or tapered, and continue to shave back until the floor wall junction is visualized. Now problem number 4, unable to observe the pulp chamber floor due to restorative material impinging onto the pulp chamber. Mostly seen with the class 5 restoration. Why? Because you have not removed the restorative material before access has begun. So always remember this law aspirant, you have to remove all the restorative materials before beginning the access. This can be a sequence based question, or they may ask in the clinical scenario that if you see the cavity, what are you going to do? You are going to prepare first access cavity preparation, you are going to remove all the leftover or the previously done restorative materials. Remember, first you have to remove the restorative materials before beginning the access. Now problem number 5 is the calcification or the pulp stone. Mostly when you see in chronic cases or long-standing trauma cases, you can see the calcified pulp canal or pulp stones are visible. Why? It indicates the degeneration of the pulp. How would you solve that? You can completely remove the pulp chamber roof and cessation of bleeding first. Then you can use a large smooth round bar, number 6 bar, a commonly asked question, to smooth the pulp chamber floor to remove the calcification and delineate the floor wall junction clearly. Now you can use this access bar also to remove the pulpal stones. Very important image based question. And also you can go for the use of sampling bubble test, that you can allow hypochlorite to remain in the pulp chamber. You can locate the calcified root canal orifices. You can see the tiny bubbles up in the solution indicating the position of orifices. This is best observed through the endodontic microscope and magnifying loops. Now this is a classical case from the Siju Jacob. Okay, you can see it's a maxillary premolar the calcified pulp chamber. What to do, aspirant? You can first of all, you can see the troughing has been done on the floor of pulp chamber with the Mohs assess refinement bar. Here the canal orifices have become evident on deep troughing, and you can see here the buccal and parietal orifices are located, and here you can negotiate the canal, and this is after proper cleaning and shaping. Then unable to observe the pulp chamber floor due to inadequate light. Why it happens? Because access is too small, presence of any crowns or restorative materials, and lack of smooth surface of walls or pulp chamber floor. How to do it? You can enlarge access until floor wall junction can be seen, remove restorative materials, and use accessory light like LED headlight or surgical operating microscope can be used, especially when metal or metal ceramic crown is present. You can also smooth all irregularities on the wall of pulp chamber with round bars. Now you can see sometimes you cannot observe pulp chamber because of loss of orientation of the burr. You can see in this diagram the orientation of the burr is completely wrong. Okay, why it happens? Because you have not used the occlusal surface as a reference point. You fail to observe tooth orientation like rotated or tilted tooth. That's why the X-ray is mandatory before you start your root canal preparation. You lose the size of CEJ circumference. In the first law, you have to locate the CEJ before you start your excess cavity preparation. And second, improper angulation of initial axis. How to solve? Proper pre-access observation of tooth orientation, proper mental imaging of CEJ, remove rubber dam during access to regain orientation, and appropriate angle of penetration of initial access burr. Now floor perforation. Why it occurs? Premature attempt to identify orifices, failure to measure occlusal furcal distance, improper identification of the floor wall junction, and inadequate access. Remedy: remove entire pulp chamber roof before identifying orifice location. Observe floor wall junction throughout 360 degree. Set burr at length less than occlusal furcal distance and direct accessing burr towards center of CEJ perimeter. Now you can see this classical case from the Clifford Ruddle book. You can see here the perforation has occurred. A small pinpoint bleeding spot is evident, and you know wherever the perforation there, the bleeding is continuous. Then you can repair the perforation with the help of white MT or biodentine. Commonly used is a biodentine nowadays, and then you can see you continue your root canal obturation. So aspirant, these are the few commonly seen troubleshooting when you go for your excess cavity preparation. And aspirant, those who want to join our Neet MDS or government dental exam test series or lecture series, test series comprising of more than 50 papers, past papers, and more than 2000 videos of lectures, and also we prepare physio, pharmac and medicine in unique correlated way. So anybody want to join, they can contact me on the number, on the mail, or directly they can contact from the website also. Till then aspirant, take care, work hard. Very few days are left for the examination, so bug up yourself and show that you have the ability to go through it.